Greetings from Indian Journal of Anaesthesia. I, Dr. Riniki Sharma, will be presenting an article published in the August 2024 issue of Indian Journal of Anaesthesia. It is titled Efficacy of Ultrasound-Guided Classical versus Parasacral Parallel Shift Technique of Sacral Plexus Block for Lower Limb Surgeries, a randomized controlled trial. Traditionally, spinal or epidural anesthesia has been used for lower limb orthopedic procedures, but they have the risk of intraoperative hypotension, urinary retention, or epidural hematoma. The sacral plexus supplies the pelvis and the lower limb and can be blocked using approaches such as the classical technique, the parasacral parallel shift technique, and the parasacral ischial plane block. Accurate identification of the nerve plexus is crucial for successful block and can be challenging due to anatomical and patient-related factors. The iliac bone contour is a key landmark for identification of the sacral plexus block. In the classical approach, the sacral plexus is visualized in the short axis at the greater sciatic notch. But in the parasacral parallel shift technique, the sacral plexus is visualized in the greater sciatic notch in the long axis, making the nerve identification easier by scanning between the ischial tuberosity and the greater trochanter. So this study was undertaken to compare the scanning time between ultrasound-guided sacral plexus block using either the parasacral parallel shift approach or the classical approach. So the primary objective was the comparison of scanning time between the two groups. The secondary objectives were needling time, first pass success rate of needle, time of onset of sensory and motor block, and total time to complete the block between the two groups. Institutional Ethical Committee approval was taken and the trial was registered in CTRI. Adult patients 18 to 80 years of age, ASA grade 1 to 3 for below knee traumatic lower limb orthopedic surgeries were included in the study. Patients who refused to participate in the study, patients with known allergy to amide local anesthetics, neurological disease, infection at the injection site, psychiatric illness, and opioid dependence were excluded from the study. Randomization was done using computer-generated random number, and the participant and outcome assessor were blinded. They were allotted into 1:1 allocation into two groups. Group C, where the classical approach of sacral plexus block was used, and Group P, where parasacral parallel shift technique was used. The block was given by anesthesiologists not involved in data analyzers. All patients were kept NPO, and in the OT, standard monitors were attached. Vitals were recorded at baseline and every 5 minutes. Ultrasound with a curved or linear probe was used, and a nerve stimulator was used. These patients, all patients were positioned in lateral decubitus with the operative leg up, rolled forward, and flexed for the sacral plexus block. So in the classical approach, the curvilinear probe is placed 8 centimeter lateral to the gluteal cleft, uppermost point. The iliac bone is then visualized as a curved hyperechoic structure. This probe is then moved laterally till the break in continuity of the bone appears, which is the greater sciatic foramen. And we can see the sacral plexus in the short axis. A 100 millimeter 22 gauge nerve stimulator needle lateral to medial is inserted, and 0.5 milliampere current to elicit the motor response is used. In the parasacral parallel shift in group P, where parasacral parallel shift technique is used, the curvilinear probe is placed between the midpoint of line joining the greater trochanter and the posterior superior iliac spine. The probe is then moved anteromedially with a PSPS till the sciatic notch is identified as a break in the continuity of the bone. So here you can visualize the sacral plexus in long axis as a dense hyperechoic structure, and the sciatic nerve motor response is elicited using a nerve stimulator with 0.5 milliampere current. So they have defined the scanning time in the classical approach as time taken for visualization of greater sciatic foramen with sciatic nerve in short axis after the probe placement. In the PSPS technique, The scanning time is the time taken for visualization of the sciatic nerve in long axis below the piriformis between the sacral and the ischial bones after the probe placement. The needling time is the time from needle insertion to proper nerve stimulation. The time to complete block is time from ultrasound localization of the nerve plexus to the end of local anesthetic injection. Successful sciatic block is complete block in all the dermatomes and a modified Bromage score of 4 at 30 minutes that allowed the surgery to proceed without converting it to general anesthesia or need of any IV intravenous supplementation. Sensory testing was done in response to cold in the anterior thigh, posterior cuff, plantar, and dorsum of foot, and in the first toe web space. Motor block was assessed using the modified Bromage scale with 4 as no movement and 1 as full movement. Postoperative pain was assessed with the numerical rating score at immediate postoperative, 6 hours, 12 hours, and 24 hours after the surgery. And if NRS was found to be more than 4, then patients were given IV morphine 0.05 milligram per kg. So the primary outcome was the scanning time between the two groups. The secondary outcome was the needling time, first pass success rate of needle, time of onset of sensory and motor block, and total time to complete the block. The sample size was based on the center's average scan time for sacral plexus block, which was a mean of 4.5 and a standard deviation of 2.1 minutes, and the reduction of 1 minute being clinically significant at two-sided 95% confidence interval and 80% power. The sample size was 138. Allowing for attrition, the final sample size was 144. A p-value of less than 0.05 was considered significant. So this is the consort diagram. A total of 155 patients were assessed for eligibility, out of which 144 were randomized. And in each group at the end, 72 patients were analyzed. The baseline characters did not differ significantly between the two groups. They were similar in between the two groups. So the primary outcome was the scanning time. We can see the scanning time was significantly less in group P, that is the group where PSPS technique was used. The needling time, the first pass rate of successful needle insertion, time to block performance, time to sensory blockage, time to motor blockage, and total successful block was significantly more in the PSPS group, in group P. In postoperative analgesia, the time to first rescue analgesia did not differ significantly between the two groups, and NRS scores at all the time points were similar between the two groups. The 24-hour morphine consumption was similar between the two groups. So this study demonstrated that ultrasound-guided parasacral parallel shift technique offers higher success rate, shorter block performance time, and earlier onset of sensory and motor block over the classical technique of sacral plexus block. The PSPS technique simplifies the process by identifying the iliac bone contour and walking off the bone. This improved visualization of the sciatic nerve in the long axis with minimal sonographic interference from the adjoining structures result in reduced scanning time and needling time. Injecting deep into the piriformis muscle deposits the local anesthesia close to the neural structure, leading to faster blockade. The PSPS approach also blocks the sciatic nerve proximally at the greater sciatic foramen, affecting the superior and inferior gluteal nerves and the posterior capsule of the hip joint, making it suitable for hip surgeries when combined with femoral nerve block. The limitations of this study include patients, is that they did not include patients requiring proximal thigh, hip, or knee surgeries, and the average BMI of the patients used of the patients in this study was less than 30 kg per meter square. Therefore, the results cannot be extrapolated to these subsets of patients. So to conclude, PSPS technique is associated with lower scanning time and needling time. Additionally, the success rate of achieving complete motor and sensory blockade in the distribution of the sciatic nerve was higher with the parasacral parallel shift technique compared to the classical technique of sacral plexus nerve block for lower limb surgeries. Thank you.